One of the things, though, that we do have to be cognizant of when we take a look at exercise is that glucose could be disrupted, the availability of it, and become hypoglycemic, which would then decrease their ability to continue exercising. So we have to really work with patients if they're on these medications to be testing their blood sugar before, after, even maybe even throughout the exercise to make sure that their glucose isn't dropping too quickly. And here's why, and I think it's one of the most profound things about exercise that I want to talk to you about. So for as far as exercise prescription is concerned, for type 1, that has an absolute requirement of insulin. Exercise is not a method of treatment, it's just merely a part of a healthy lifestyle. But for type 2 diabetes, it is a method of treatment because it can improve insulin sensitivity significantly. So when frequency and duration of exercise are sufficient, exercise can really improve the diabetic state in the individual. And here is why. Exercise actually mimics insulin. So if you will, insulin is needed, as we talked about before, to bring GLUT4 up in the cell and to be able to, insulin's needed to have a cascade of signals that causes GLUT4 to come up to the cell to allow glucose in. And one of the things that you will notice here is that this signaling cascade, as you remember from when we talked about type 2 diabetes, gets disrupted such that insulin's present, but it's not, the receptor's defective. It's desensitized, insulin resistant. It doesn't work with insulin to cause this cascade signal, and so we have glucose building up in the cell. But what exercise does is the act of movement or contraction of your muscles actually causes that signal cascade to occur in the cells and results in GLUT4 coming up and allowing for glucose to enter in to the cells during exercise. That is not being done without without insulin. So you see here, insulin's not being activated at all, and yet GLUT4 is coming up and getting ready to allow glucose to come into the cell. And so one of the things that exercise does is it actually acts as insulin. And so we know that exercise can be a treatment for type 2 diabetes because we don't need the insulin, which is resistant. And if you remember what I said, what happens in insulin resistance is then the pancreas or the beta cells are going to produce more insulin to try and get these things to work. And then over time, those beta cells are going to die. They're not going to work well, and they're going to have run their course. And then this leads to a progression in diabetes that results in a need for insulin injections. But what we find with exercise is because exercise doesn't need insulin to get that GLUT4 up to the cell, what it will do is it actually helps to clear that glucose, meaning that the pancreas does not need to produce an insulin. It allows those receptors to have a break, your beta cells to have a break, which improves insulin sensitivity actually over time because it's not being overworked in either of those compartments. So exercise is used as a treatment for diabetes. It can potentially reverse diabetes if done with weight management if the person is overweight. We have to look at other risk factors, but it is very profound, and regardless of diagnosis, we encourage exercise throughout. And that's what this kind of talks about here. Is this slide kind of shows you that we have our skeletal muscle here that exercise affects. It's going to affect the pancreas, it's going to affect adipose tissue, and it's also going to affect the liver. And so as you break this down, the skeletal muscle, it'll increase blood flow, which increases muscle glucose delivery, which then helps to control blood glucose. It works with the quality of the muscle. Again, it increases capillary density, fiber type changes, and biochemical changes, which results in increased insulin receptors, a faster insulin cascade when we're at rest, and up to increase of GLUT4. So the number of GLUT4s that we actually have in the muscle increases. increases in hexokinase, and increase in glucose disposal enzymes, which ultimately leads an increase of muscle glucose extraction, blood glucose control. Increases of muscle mass, which allows for greater glucose storage in the muscle, which leads to greater muscle glucose extraction, and again, better blood glucose control. Exercise training, again, works with the pancreas and decreases hyperinsulinemia because it doesn't need to produce as much insulin for the same effect. Adipose tissue, it's going to help to reduce abdominal obesity, which we know has some factors related to insulin receptor density, GLUT4. Those things begin to improve, better uptake of glucose, free fatty acid clearance, better glucose control. It leads to decrease in free fatty acid release and decrease in gluconeogenesis, or in other words, the production of glucose, blood glucose control. And then it also improves, we think, TNF-alpha, which is a hormone that can further lead to damage, as we talked about in macrovascular disease. And again, that can improve muscle glucose extraction. And then, of course, in the liver, it increases insulin sensitivity, allowing for better glucose control. So it is a system-wide impact on how it controls glucose, lowering insulin and also improving the sensitivity of insulin, and overall improving glucose control. So again, it's really important for individuals to be able to, if they are, are diabetic or on medications for diabetes, to make sure that they are checking their blood sugar, because exercise can put them in a hypoglycemic state. So again, there are individuals trained in helping them to do this and to regulate this, and can work with them on getting regularly tested with their physician as well to see if they can lower their medication or come off as well. So exercise is one of the primary keys to control, and as you can see this, it has a significant impact on control of the disease. So, but it's a complex lifestyle change, and it's going to take individuals a lot of work in order to get this to be a part of their lifestyle, which again takes more than one counseling session. So just wanted you all to keep that in mind. It is feasible and it is possible. And something that we're doing with public health is trying to train more healthcare professionals in their ability to do some of this counseling, but also just educating them on referral processes to have really more of a team approach, a coordinated care approach with other practitioners in the healthcare system outside of our traditional healthcare practitioners to help engage people in these behaviors in order to move forward with that. And so one of those areas that we had that really helped to do that was something called the Diabetes Prevention Program. This was done all over, it was done in several different sites, but one of the sites that was done was at the University of Pittsburgh. That's where I graduated from for my master's and PhD. So I actually had the privilege to work with these individuals, not on the Diabetes Prevention Program when it was going through, but afterwards on other interventions related to diabetes control. Prior to being a professor, I developed interventions for lifestyle behavior change. And one of the big things about DPP is it really changed the face of the way we look at healthcare again. If you remember, we began to realize with nutrition that the absence of something beneficial can lead to disease. And what we have found is this is particularly true in chronic disease. So what this study did is it actually had 4 arms initially. It had 2 drug arms, a placebo group, and what we called a lifestyle behavior group. The drug, one of the drugs actually was I think it was about 2 years into it. This was a 5-year intervention. About 2 years into it, it caused deaths among individuals. So they actually stopped that arm and continued forward with only the placebo and metformin and lifestyle behavior change. And what they were looking at was how these 2 factors, the drug or lifestyle, impacted the incidence of type 2 diabetes in those that were pre-diabetic. For the drug therapy, they were consuming about 850 milligrams of metformin twice daily. And the lifestyle intervention focused on a weight, reducing body weight. It was a 7% weight loss. So not even the clinical weight loss of 10%. They were focusing mostly on the 7%, improving their diet and increasing their physical activity to about 150 minutes. So I think that goal was actually 175. So they were not initially doing really high levels of incidence there, or high levels of physical activity that we typically see with weight management programs such as closer to 300 minutes. And what you're going to notice here, over here, okay, this is looking at change in weight. And the first thing you can see is that we saw a significant decrease in weight for the first half the year, first 6 months. It maintained it to a year, and then it slowly, steadily came up, but really leveled off still at a nice reduction up to 4 years. And this is typical a curve of what we see with weight loss interventions. Individuals are really successful, can maintain it up to a year, and then can slowly regain their weight back for various reasons. So we've still got to work on adherence there, but significantly more weight was lost with that than it was with metformin. When you look at change in physical activity, obviously the metformin group followed very closely to the placebo. Look at lifestyle. Significant change up to a year. It's kind of declined, went back up in the other year. This is typical of what we see, kind of goes back and forth, but for the most part it maintained much higher levels than baseline and way more than the metformin group. What's really important here to look at is you can see incidence of diabetes. This is cumulative incidence and percentage. And what this is showing you is the reduction in incidence of diabetes, and lifestyle had a far greater reduction than metformin. The reduction was actually 58% lower incidence of diabetes in the lifestyle group compared to only about a 31% lower risk in the drug therapy group. This was so profound that they actually stopped the trial early. They did not continue on to year 5 because the metformin group, it would have been unethical to not give it to these two groups because of such of a reduction in this. They went on then to test a diabetes prevention program in several countries, in several different forums. It is now a national program that we offer. It is typically covered by insurance purposes, and we can also offer it in different areas. We are working to try and set one of these programs up at St. Francis on campus. we're hoping to do this in the next couple years. We did a trial run of it. It was pretty successful. So we're just hoping to maybe do something like this more extensively. But the DPP program is now called, you can find it by looking up National Diabetes Prevention Program, but it's now actually called the Prevent Type 2. So you can look that up as well. I've given you a resource page of some articles that I'd like you to read, but I've also given you a video that talks to you, that you need to watch. It's about a 5-minute video that talks about the National Diabetes Prevention Program, what it looks like, what's typically involved in it. And then I gave you a couple pages to print off or to save to your computer that gives you resources to find these programs, refer individuals to these programs, highly successful programs in order to change the face of diabetes in our country. So it's Prevent Type 2. So we really want to work on those pre-diabetes patients and try and get them not to have diabetes at all. But we can also utilize programs like this for those that already have type 2, especially early on with weight loss and lifestyle behavior change, because in some cases we have seen a reversal of the disease to those that have been adhering to it. So that's all available for you. I also wanted to show you here, this is from the Nurses Health Study. This is one of our large epidemiological prospective studies looking at factors that can reduce the risk of disease and or risk factors that cause disease. And this is just showing you different types of walking speeds. And what you're going to see here is age-adjusted relative risk. And remember, relative risk is telling us the risk of disease. And what you can see is those that do just a normal walking pace of, about 2 to 3 miles an hour, up to about 3 miles an hour, have a reduction in their risk of diabetes, developing diabetes. And then it further even decreases